And good Wednesday afternoon to everyone. TJ All, it's I-45 now in Galveston now. And welcome back to our January edition of Healthcare Unmasked presented by UTMB. And obviously the hot topic that's been going on actually well before we got around here was dealing with the latest COVID surge and Omicron variant that's out there. And we brought in the two top experts that we have in our region, Dr. Philip Keiser, UTMB Health's infectious disease expert, as well as the local health authority for Galveston County, and our friend Dr. Janek Patel, UTMB Health's director of infection control, and who's been leading the vaccination efforts through UTMB. Thank you both for being on with us here today. A lot of questions folks have out there, what we're dealing with. First, let me just, get into this right now, right off the bat. Dr. Patel, let me just ask you, just how we see the news reports, everything else, just how bad is this surge that we're seeing right now, thanks to Omicron, when it comes to COVID-19?
Well, I'll give you my perspective of the health system. And I know Dr. Kaiser will weigh in from the community side. And so, our UTMB clinics and inpatient areas really have borne the brunt of this surge. It's massive, biggest ever, and I'm sure your viewers are not surprised. Um, we have done record number of tests in the last month. On some days we have done almost 3,000 tests a day, and with 30 to 40, even some days exceeding 45% positivity, and that's really massive. We also have had increased admissions, and we can talk about it later on. Um, Fortunately, those are milder cases, but our health system is really working at full capacity uh, with staffing shortages as well. And so we do have significant number of COVID admissions. Thankfully, most of them are not very ill, although we do see some mortality on a daily basis. So it's massive in terms of its scope in the health system, and we may be reaching the peak, or maybe in a better place in a few days, and Dr. Kaiser will add. But yes, by all accounts, it's massive here.
And you brought up something that's very important here, because when we talk about capacity within the medical system, there's two parts of that. It's the physical structure and the physical the items that you need for treatment, but then it also comes to the personnel. And like medical systems across the country right now, thanks to everything from burnout to finding other opportunities and the like, how significant is the staffing shortage right now, particularly within the UTMB systems?
Um, it's quite significant, but actually there is some light at the end of the tunnel in terms of employees that were home because of COVID. That number is declining. In fact, it has dropped much more sharply than the community rates of infection. So that's the good news. And we have adopted a new policy of earlier return to work, within or after 5 days of infection, if they're better with a negative antigen test. So in that sense, some of the shortages have been averted with declining rates of infection as well as earlier return to work. But then there has been this continuous build-up since the pandemic began with the burnout, as you had mentioned, and that has led to people just leaving healthcare field, and that has not improved. And so, yeah, the challenge remains actually, and again, is compounded by the COVID illness among our employees. So that's a problem, um, and I think long term, we'll see how the healthcare field, is able to replenish the workforce that left. That's a challenge nationwide.
Dr. Kaiser, let me bring you in on this conversation. We've heard how at least from the UTMB perspective, is I wonder if too, because you also in your role as local health authority keep track of what's happening with the other hospitals in our region. Are they having similar situations of with the HCA hospitals particularly, that they're seeing the same thing, where influx of patients and at the same time that they're having some staffing issues at the same time?
Yeah, this is a nationwide trend. And we're seeing this, in our county, we're seeing it in Houston, we're seeing it all over the country. And, certainly with Omicron, we've seen higher rates totally dwarfs the number of cases that we've seen before. Fortunately, most of those folks are not getting that sick that are requiring hospitalization. So when you look at the rate of hospitalization, it is about 50% of what it was during the last surge with Delta. Okay. That being said, just the whole number of people means that there are a lot of people getting hospitalized, and most hospitals are pretty much at capacity, and that's being limited by both the number of beds and the staff that's available. And so the good news is that the death rate hasn't caught up yet. And so we're not seeing nearly as many deaths. We're seeing fewer ICU admissions than we are seeing in terms of just general hospitalizations. And overall, people are not as sick. But you shouldn't take that as saying, oh, if I get Omicron, I'm not going to get sick, because there's no guarantees here. We're still seeing people get really sick and still seeing some people die.
And on that, when we talk about that, we have, folks are not as sick in a general sense. We should point out that it varies. But is that, would you say, because most who are maybe getting sick are some of the breakthroughs, and then they're just dealing with it better, or is it that this may not be as a harsh of a variant as we saw with Delta, for example?
Yeah, I think it's not making people on average as sick. And so there's one study that came out that said, it signed a number of like 50%. Okay, now what does that really mean? But people tend to be less likely to end up in the hospital. They tend to, compared to Delta, less likely to end up in the hospital. Their symptoms tend to be not as severe, and they tend to be not as long lasting. I've actually talked to several people who've had it twice, where they've gotten infected with Omicron, and prior to that, they were infected with one of the other types, and they said they felt just as bad, but it didn't last nearly as long. So, the virus is different. I think probably the most significant thing about this is that it can evade the immune system in terms of infecting people, but people who are fully vaccinated are very, very unlikely to end up in the hospital.
And as we have all seen during this entire conversation now for over a year and a half now, really, that what we're seeing is a lot of the rhetoric of that vaccines aren't working or those type of things and breakthroughs. I just wonder if you could both put in perspective, as we're just now seeing the new numbers from the county health district come out just as we're doing this, and I'm reading this straight off the screen. 423 additional positive COVID-19 cases. Now, take that to when we were looking at things when there was no vaccine availability and things were spreading. We weren't seeing many of those 300 plus infections coming in there once the vaccine started, and now we're starting to see this on a regular basis. Of the folks that are having through, what percentage are you seeing that are breakthrough? Versus those folks that are not vaccinated that are contributing to these higher numbers on the daily count. And I should point out that 467 is the daily count. It's not a weekend count or anything like that.
Right. That's the number of cases that we're reporting out today. And of course, just keep in mind that doesn't mean those people were all tested today or yesterday. That's that's as they come in. But in general, we're seeing about 10% of our cases being breakthroughs, and which is much higher than we didn't see any breakthroughs, minimal breakthroughs, with Delta, and that's much higher, but it still represents a minority of the cases.
Yeah, and that's the incredible thing. I wondered too, Dr. Patel, on this, because one of the things I've noticed is that the high number of positive cases that have been we see those and it's like, oh, it's up high here. But one of the things is I'm just kind of correlating it when I then go look at the data of, okay, yeah, someone's tested positive here, but how sick are they? Are they in the hospital? Yeah. And the like from that. And I wonder if we lose focus sometimes in kind of the general discussion on this, and feel free as well, Dr. Keiser, to bring on this, that in the general discussion that maybe looking at just the number of total cases of positive cases isn't the best number to be looking at now in context. It's important, but in context, look at how many people are actually getting sick, how many people are missing work, school, or have to be hospitalized, or those type of things. And I wonder too, do we need to be refocusing the discussion on, all right, and it's harder to track that data, obviously, of how many people are really getting sick at this point because the vaccines are there. We have the new pills coming online. There are infusions. There's better therapies and treatments than existed before. And I just want to get your perspective on that, Dr. Patel, of should we be more focused on the effects of after being positive versus just being positive for COVID-19, particularly with Omicron right now?
DJ, I think you're right. Actually, probably that would be the thinking for the future, because it is becoming clearer that COVID will never leave us. Obviously, variants will come and go, and therefore people will get infected. But the idea will be: is it severe enough to affect your health and resulting hospitalization or death? And so, I think we are going to be moving towards that, and this daily count of positive cases probably would have less meaning or less focus, and maybe we'll be talking more about those who are requiring medical attention for severe illness. And I think, yes, that's probably the way to move forward with this infection. Omicron particularly actually has bigger issue with this because it's so much transmissible, and it infects even vaccinated people that it's probably not relevant to say how much it infects everyone. So I think severity probably should be our focus moving forward. And you had earlier, mentioned issues around hospitalization and the vaccine effect. I was just looking at the number today at UTMB. We have 172 COVID positive cases in our health system. As you know, we have 4 campuses, so these are all spread out. And out of that, 35 patients were vaccinated. So that means about 20% breakthrough. But if you look at those who were hospitalized because of COVID, then it's less than 10%. So I think that's the impact we want to see in terms of vaccinations effect on hospitalization. If you look at mortality, we have reported very few deaths in fully vaccinated people, and Dr. Keiser has that information. And in fact, among those who have received booster doses, we only have had 3 deaths, but again, those were highly immunosuppressed patients or, very much elderly folks. So that shouldn't surprise us. The vaccine doesn't protect us completely, but it does a great job in preventing symptomatic admission as well as death. I was also looking at mortality right now with the Omicron variant, as we had all alluded to it earlier. It is fortunately a strain that causes milder illness by and large, but again, not everybody's lucky. So we always have to remember that. We have to still respect this virus very much. So I was looking at mortality currently, like this month, it is, it is about 6% of our admissions result in mortality right now. But if you look at the last wave, the Delta wave we had last summer, it was twice that much, so 12%. So we have some benefit in terms of this Omicron's less virulent nature. So, I think we have to balance everything. Infection is very common with Omicron, with or without vaccine. That doesn't mean we should say that vaccine is not working. It's really working. Severe outcome.
Right. It comes down to it, Dr. Keiser, is that if we hear folks say, well, the vaccines aren't working, actually, the data shows the exact opposite. When you talked about that right now, if you see a 10% breakthrough, actually, the effectiveness rate of particularly Moderna and Pfizer is at 80 to 90% range. So that would seem to support the data on the research all along that, you're going to have 10% of the breakthroughs, but that kind of was built into what was expected versus, and I don't want to lessen the effect on anything, that flu vaccines have around 40 to 50% at the best on those rates, and you still folks who are vaccinated for the flu still get the flu. And I wonder too, is that where do you think sometimes folks are losing the perspective of what we need to be talking about when we do this? Is it infections? Is it how sick you are? What should we be looking at there?
Well, it's a good question. I think we need to look at multiple metrics depending on what we're talking about. But let's just put the whole thing in perspective in terms of breakthroughs and deaths and hospitalizations. So, among Galveston County residents, we've had a total of 6,118 breakthroughs, okay, since the beginning of the pandemic. Most of those, probably about 4,000 of those, have occurred with the Omicron. Okay, so there are breakthroughs that occur, right? But speaking to the point of does the vaccine protect against hospitalization and death, I think you really see that when we've only had 129 hospitalizations in breakthrough cases. Okay, so people get the virus, and only 129 of those 6,000 people who have gotten the virus despite being vaccinated have actually ended up in the hospital, and 50 have died. Now, most of those 50 actually are from Delta, not from Omicron. So the vaccine works. It is extremely effective. And I think part of the problem that people have is, everybody wants it black and white. It works, it doesn't work. This is the number, that's the number. So, in terms of the effectiveness of the vaccine, I think you got to look at the whole picture. In terms of looking at the rates of infection, particularly with Omicron, that's very helpful from a public health point of view because it helps us determine how rapidly things are spreading. And if you look at the data that we've been presenting in the last couple of days, you see that Omicron took off like a rocket and it's coming down like a stone. And so, today our numbers are even lower. We had reported as many as 1,000 cases a day. That was unheard of. Today we're celebrating. We only have 400 and some to present.
Right.
Right. But in the day of Delta, 400 would have meant the hospitals were completely full with really sick people. Right. Where now the hospitals are tight, but the people aren't that sick and they're not dying. So, for an individual, what it means, I think it means that if you're fully vaccinated, your chance of getting sick from Omicron is pretty low. If you're not vaccinated, you can still get sick and you can still get in the hospital.
Right. I think, though, too, and maybe we get kind of bogged down in our own discussions on that. And matter of fact, we're showing the latest data we have from UTMB. And again, this is UTMB statistics, but UTMB had 28 vaccinated and 139 unvaccinated individuals hospitalized across those 4 hospitals. And this is yesterday's numbers, by the way, that were compiled for this show. So when we talk about, I think too, what gets lost maybe in this discussion is that it's like, oh, the vaccine's supposed to be the magic bullet. As if, maybe it's an unfair comparison sometimes to say, well, the polio vaccine, that's why we don't have polio any longer. That didn't happen immediately. I mean, we should know that it took years before it became that. The goal right now is, with everything that's going on, is to take COVID-19 from a pandemic to an endemic, right? Just bring it down a level that we can, quote unquote, live with it. Is that a fair what we're talking about this process now? As I said, a year and a half, but it's really March of last year to now that we're really discussing this.
Yeah, it's been. I mean, for Janek and I, it's been 2 years. We first started planning about this Martin Luther King birthday.
Yeah.
Tuesday after Martin Luther King birthday. So it's been 2 years for us.
Mm-hmm.
And it's been a long 2 years. But, I guess the real question is, what can we realistically expect? I mean, we had hoped that vaccination would allow everybody to be protected and not have to worry about this anymore. And that's not the case. And I think part of our optimism was due to the fact that these vaccines have been so successful. If it first came out that the vaccine was 50% effective, we would have been delighted. And then when it came out to be 92% effective, that's wonderful. But I think it probably, both for healthcare providers as well as for the general public, it may have raised expectations a little too high, and that's why there's disappointment. But when you look at it writ large, the vaccines work extremely well. We may very well see variants come and go, but the real question is how well will the vaccines hold up in terms of protecting us? And so far, so good.
Well, and I
I,
thought one of too is that it's what Dr. Patel is that and we see it with every time Dr. Fauci goes, Dr. Anthony Fauci, a White House chief medical advisor, goes onto the Capitol Hill and gets into the fights. I, I think some of this frustration is the effects away from the illness in the health treatments. It is when we had lockdowns and we had restaurant closures and everything else, that folks are worried that when these numbers come out, then the next thing you know, we're start hearing about those again, and that those are existence in some places. But right now, at least where we are, it's certain recommendations are in place and certain businesses have their own rules, but there is no state requirement. There is no local requirement. And in many cases, there are some like in Harris County and within schools and the like, that there's a bigger discussion when folks express the whole frustration with that. Like we got to live with it. Which goes to a question because one of our viewers asked here, and I got to give Moon here a chance. Moon Dead Car says, "Do you think COVID will go away?" Dr. Patel, you said earlier no, but let me just add the caveat to that: do we get to a point, and then how soon from now do we get to just live with it and deal with it just like we do with the flu or pneumonia?
I mean, look, anything we say today will be an optimistic.
Right. Yeah.
Nobody really knows. All I can say is that this virus is so human adopted right now. I cannot see it go away. Okay. It is the most transmissible. That means it finds the human host to be the most, easy host. And so why would it go away? It latches onto people's nasal passages and, infects readily. So it's no longer a rare disease. It's no longer a disease of the few. It's not a disease that has very well set of symptoms and signs. You can isolate people quickly and treat them. It has asymptomatic condition. It has mildly symptomatic condition that resembles a common cold. So when you have this kind of variation of presentation, is huge advantage to ready infectivity. It is going to stay. So how do we contain it? Is always going to be a global answer, right? And I think it's going to be through various mechanisms. One is, again, vaccination, tweaking the vaccines, boosting the vaccines, having therapeutics available, easy diagnostics available at home. Make sure the rest of the world, is marching along at the same time, because, the variants are expected to pop up here and there, and they're going to pop up in places where they have poor, access to preventive methods. So I think it will only get under control when we do better globally. I think locally in the US, we will probably continue to do well if we have access to vaccines that are continue to be tested for its efficacy against the current and possibly future strains. But again, we just have to be ready to pull back or sometimes move forward, to normality. Yeah, I mean, people are nervous. Who has experienced a pandemic in their lifetime, right? So we really don't know how to behave, right? We really, it's a collective, psychological process, and I think I'm just as much in it as the general lay population. Okay, we all have optimism, and we should keep that, by the way. Okay, because I think we are doing better. We have more tools. We have so many advances. So I cannot imagine that we will lose all the benefits we have gained. And I think we'll make even more progress in the future, that we should be able to live with this virus as a new norm. Yes.
Dr. Keiser, do you want to chime in on that as well from what Dr. Patel just said there?
Yeah, it's hard to know. I mean,
living with it.
Yeah, I mean, it's hard to know. I mean, each virus that we've seen has been different. We had, SARS and MERS, and they came and went very quickly, and COVID actually did not. And, you also compare that to, the flu epidemic of 1918, which is, I think this is probably the most analogous but different. And what happened? Well, flu never completely went away, right? And there was a group of people that lived through 1918 who had really good antibodies, and the flu years were mild for a long time. And then starting in the 1940s and 50s, you start seeing, these outbreaks in the 60s and 70s with variants that escape. And so we may very well end up seeing exactly the same thing with this virus. That being said, you get to that point, then I think it may actually look like flu. Certainly with Omicron, all of our things are closing things down, and aren't particularly that effective. Why? Because this thing is so much more infectious, and we're seeing people get it everywhere. And so we closed down 2 years ago in large part to try and keep it from spreading rapidly as it hit our shores, and that was probably an appropriate thing to do for a short period of time. But one of the hard lessons we learned is you can't just keep closing things down every time the numbers get high, because it damages the economy, it damages people's psyche. There are negative consequences, unintended negative consequences of that as well. So, I think as we work through Omicron, we're kind of working through what is the future going to look like. I can't overemphasize the importance of rapid diagnostics and also having pills available. And we've talked about this before, but they're coming slowly. But hopefully within the next few months, you get COVID, you go to your doctor, he does a test and goes, here's your script, go to Walmart, go get it and take it. 2 days, you feel better. That will have important things, not just in terms of making feel better and keeping them from getting sick, but also have important public health effects, because if we can have widespread treatments, then once people get it, the amount of virus in their nose is going to be much more rapidly, and have much less opportunity to spread it.
On that, and that was going to be a question I asked later, but I'll ask it now, on the Merck and Pfizer pills, how soon are we going to be able to, I go to Dr. Sood over at UTMB and she writes me a script if I have a breakthrough case. How soon do you actually see it as a routine?
Yeah, they can write you a script right now. Whether anybody will fill it is a whole other matter.
Right.
We follow the allocations that have come out. So the first allocation for Texas was basically 4,000 of Paxlovid, and I think the next group is about 40,000. So they're really ramping it up, and looking at the speed, it will probably be a couple months before there's enough of it around that can happen in a reliable fashion. So if you can score Paxlovid, you basically won the lottery. But we're just going to have to wait and see. It'll take time.
And it should be pointed out right now, it's only being recommended for folks that have, that would be at a very high risk for severe illness or death for that. But the idea is to get enough production done that then it can go to folks that get sick overall. This gets into another question. I jokingly had asked Dr. Patel if he could make sure that we could have a booster every month. Type of thing, but there's a lot of talk about the fourth booster. Stan Van Horn, who's a regular viewer of ours, says, can we get the fourth shot yet? The second booster. CDC says 6 months for Moderna, and he called the district and said he's clear that they do my second booster, fourth shot. Yeah, it gets confusing out here. What's what, what's when, and where. Where are we as far as at that time of seeing that fourth booster? You were telling me, Dr. Patel, that there's some trials going on in Israel right now that are showing that the fourth booster may not have that much of an effect on preventing more an effect, not much of an effect, but more of an effect on keeping folks safe.
So as you know, in Israel, they do things rapidly, right? It's one national health system, and it's like they live their lives in a military way, and so they were the first ones to try the booster, and where everybody else was saying it may not be needed, and it was obviously they were right, it was needed. So they got their third dose, which is the first booster, and then now for the last month they have been doing the fourth dose as well. And they are now not finding additional benefit over third dose. And that probably won't be surprising, because I think that third dose wasn't that long ago. It was about 2 months ago. And so fourth dose soon after that. I think whatever benefit you are going to get out of that boosting with third dose, against Omicron probably was good enough, and it wasn't going to add anymore. I think that's the take. And I think most people don't think you will need boosters that frequently. Okay. unless a new strain comes along that totally has no impact, from the currently available vaccines, then yeah, we need a next vaccine as soon as available. Um, so again, how frequently need the booster doses, I think will be determined by the future strains and how much antibody levels are needed against those strains. And, with Omicron, we needed higher level of antibody to protect compared to Delta. Okay, so uh, again, it's going to be changing science, changing recommendation. And I do want to make a comment. You had earlier mentioned, people getting confused and Dr. Fauci on the TV, taking the brunt of all these, people's ire. But I think what we have to tell people, there is not a one-time answer. Everybody wants a black and white answer once and for all, and there is no such thing with this COVID pandemic. If we said something today and we change it, in a month, be prepared for the change. We learn along the way, and so it's not like we are wrong today. And I think that's what Dr. Fauci is taking a lot of blame for. That it's been confusing, but it's been with whatever information available, and we'll keep on changing. I think people have to be ready for that.
All right. And it goes to the conversation all of us had, I would say, when we were looking at things last spring and summer when things were trying to get to, and so here it goes to when it's like building the airplane as you're in flight. I think that was the term we used a lot of times. And there is going to be that, but there seems to be, and maybe it's how it's being delivered, the message to the general public via the media or just folks not understanding in context. But it does some, and Dr. Keiser, you and I have talked about this several times, this mixed messaging that comes from when you look on high and the FDA says one thing, CDC says another thing, and it goes back and forth, and it seems like, and I look for the context of it, of like this whole mask thing, like, well, it can't report it early on. Well, everyone has to go to an N95 or a KN95. Well, really what the report said was this is just the better mask. When it came out, didn't say everyone had to have it, just this is more effective compared to that. But it got out in the general public as a different kind of messaging. How does that need to be? We've talked about this several times. That really needs to probably be improved overall. That that on the healthcare, communicating to the public, it needs to be a little more succinct, but also not, or as I call, nerdy talk. Where folks understand what's being said to them, right?
Yeah, no, I mean, unfortunately, we do that a lot, and we talk down to people a lot, and sometimes be condescending. And then also when, the other thing I see a lot of public health officials do is, when something changes and they're called on that, they'll go, well, that's because now we know, it's all very, like I'm the smartest guy around, as opposed to saying, gee, we're sorry, we didn't mean to mislead you. And so, I think you have to approach this with a sense of humility and a sense of trying to get the right information out there. But it's hard, I tell you. Sometimes we'll tell people things that we think are pretty clear, and people misunderstand it or misconstrue it. And then once that happens, it kind of develops a life of its own. But I think one of the real keys that we've learned is that trust is the most important commodity in public health. And the way you develop trust is by consistently having open dialogue and consistently acting in the community's interest. And sometimes those interests aren't, they clash, and sometimes you get mixed messages from government. I mean, we're seeing it now, like with the whole 5G thing over airports, right? Two different government agencies are saying two different things, and so this is not something that's unique to us, but it's something that we definitely need to work on in the future.
Also, too, this is something that we probably need to kind of put in perspective too. You had said it yourself, Dr. Patel. Was the last time we had to deal with many people were around. Last time it was a worldwide pandemic. This is not, in the past when we've seen certain things like this, they've been isolated to regions and not spread globally like this, which puts a strain on the healthcare system. And different folks take different approaches to things, because you talk about how Israel approaches something, how the U.S. approaches something, how India approaches something is different, how South Africa approaches something is different. But it has been a long while since the world has seen this type of a thing. Does that play into this as well? Because there's just so much messaging coming out at the same time.
Yeah, I mean, I think we are a victim of the ease of communication. Okay, so there is a lot of information and misinformation. So we are bombarded with messages from around the world. Okay, and you know, you develop your own ecosystem. You know, you feed on each other, and so I think that amplifies sometimes messages, and that can confuse people. And you know, this happens in our own healthcare system, where we have people who are supposed to be more connected with the science. um, Even here, you know, we have to be very diligent about the messaging we send out, and they do get confused, and we always have to, you know, talk to our employees, listen to them. I answer several emails and, you know, phone calls every day, and I'm sure Dr. Keiser does too. We have to be ready to help. um, yeah, I think sometimes too much access to information from everywhere uh, is a problem, and it's just not for COVID. I know this happens with everything, you know, election or whatever you look at.
Mhm.
There is always this kind of issue around who should police the right kind of information and all that. People have to sort it out, but I think it's going to be very hard because of globalization, you know, of information.
And it goes in, and Dr. Kaiser goes into the conversation we've had all along about that messing. We had somebody here says we need that I just put up her comment about it, that COVID needs to be normalized and a set protocol needs to be set. That may not be the best way either. Is that what works for one set of folks may not work for another set of folks, right?
Oh,
There is no magic bullet in all of this.
Yeah, unfortunately, that's just so true when it comes to messaging. You know, it's very important to understand where people are coming from and you know where they live and what their personal situation is, because people hear things from the point of view is how does this affect me? And you know, when we say something that kind of is meant as a global generalization, they'll hear it from a very specific point of view, and so you have to be willing to address those types of questions and concerns that people have, and it's hard, and it's hard to get everything right, and then people get frustrated and angry, and then that makes it even harder to get messages across.
And again, this is the lesson also learned along this is how I get the way to kind of do it is how to communicate it as well as how to administer the treatments, and
Mhm.
those are often it goes to the old thing, I guess both of you learn, they, as I said, they don't teach bedside manner in medical school a lot of times.
We
Right?
try.
I mean, we try, but that becomes a little bit different, because it's not, the bedside manner setup is different, for different doctors. We can all say, hey, I don't like that doctor because the bedside manner is not as good as, oh, I do like that doctor because he or she is more direct. And so, it just kind of depends who's the messenger sometimes. And sometimes both of y'all have been targets for stuff. We've got comments out here that some, because they contain curse words, we're not putting them up out there. But folks, that, they want to call names and everything else. And we've gotten used to that, I think, on the show. And we deal with the facts of it, which is, learning every single day, make improvements on. But I think I heard something important from you, Dr. Keiser, that admit when you make a mistake, or hey, what I said the other day probably needs to be updated, and that goes into the trust. You've done that several times on our weekly visits of like, well, I said that a month ago, probably like this way now, right?
You talk about bedside manner. So when I was a fourth year medical student, I walked into a patient's room once and I asked, what's the problem today? And he goes, what do you mean, what's my problem? And so, people hear things differently. And so you have to be prepared for that. And And then when you do miscommunicate, you have to take the onus on that. It's not like, oh, that guy was crazy, so sensitive. I don't know what his problem was. What his problem was, I thought he had a problem.
Right.
As opposed to what brings you to the hospital. And so you have to learn for different audiences how to try and craft your messages in ways that people are open and listening. And that's hard because we're always going to make mistakes. We're always going to screw it up. We're always going to offend somebody somewhere. And you just try and do better each time.
At this time, though, you talked about earlier about we saw this spike go up and then it dropped like a rock. But what's the next? Let me use the term drop. What's the next shoe to drop? Do we know? Do we see something somewhere else? I mean, I'm asking both of you to get your crystal balls out. What's coming next?
I have no idea what's coming next.
Yeah,
I would say it's when it's down. Enjoy the break. Hopefully, it lasts a long time, right? But we have to keep our eyes and ears open on what's happening around the world, and I think we have gotten better at that, trying to see what's emerging in different parts of the world and see if that's of a concern, and redouble your effort. We've been doing that actually for the last 2 years, keeping an eye on things. We just have to, from public health and healthcare system perspective, we have to keep our focus on this thing. I think while general public can try to normalize their lifestyle, we have to be very cautious at our health system and public health level.
I have Bob Lewis is a guy that been commenting on here, and he may says, "Well, can we get some opposing views?" Let me just kind of point out something here. We find a doctor who wants to come on and give opposing views of this. Every time I've asked, they've not wanted to do so. They'll say, "Oh, go talk to this doctor. Go talk to this doctor." Okay, fine. They have declined every single time. Now, the only one who has not declined us is Dr. Robert Armstrong, who's come on, who has done things with hydrochloroquine, for example. We got a lot of national on that. But he even said to me in an interview, said, "Hey, this is not the magic bullet either. This is just something we tried here. It had some effectiveness, and sometimes it didn't." But the thing is that I did see something I did find interesting. It was a question actually that Dr. Fauci was answering to the former Auburn coach, Tommy Tuberville, who's now a U.S. Senator out of Alabama. And Tuberville had asked, "Okay, can you talk to me about ivermectin?" All right. Now, what we know of ivermectin based on the studies, these are actual what studies have been done, granted limited, and show it's not that effective. However, he said something I was not aware of. He says there actually is kind of a revisit happening of ivermectin in some circles of researching that. And I think sometimes folks don't realize that even the things that there's not everything has not been totally discounted, but there are some things being looked at, and I think that's part of the process that maybe we don't hear enough of. That yes, we're looking at everything that we can out there right now, and that but what we have that's working right now is what's working right now. Is that a fair assessment to talk about it in those terms?
Yeah, I also think that even things that the general medical community thinks is a good thing aren't necessarily playing out the way we expected them to. So, for example, remdesivir, when it came out, we had hoped that this would be a magic bullet for this, but it's certainly no penicillin, and it does have some effectiveness. But the more we use it, the more we realize is that there's a very, very narrow window when it's effective. And so, when you look at some of these studies with hydroxychloroquine and ivermectin, they've been either so small you really couldn't make any inferences from them, or very large and covering a lot of people and not seeing a whole heck of a lot of differences. And so I think what we're seeing is as that data gets looked at and digested and sliced in different ways, then people ask the question, well, in this particular instance, maybe it has some benefit. And so because none of our therapeutics are that great, I think that we'll continue to see that revisiting of current therapies, new therapies, and old therapies. It's something that hasn't gotten talked about very much in terms of effectiveness in treating COVID is an antidepressant. And actually, the data is really good. It has about a 30% reduction in mortality and death, and it's available and it's cheap. But it's not talked about a lot. So I think there are lots of things out there which may be useful, that as we gain more experience and as we have more data to look at and try it in more situations, we'll have a much better appreciation of what's useful and what's not. And then if you want a prediction, here's my prediction, that at some point someone's going to come up with a really dynamite medication that's just going to stop COVID in its tracks, and all of these other discussions will be forgotten.
Right. Well,
if I may add to the therapeutics discussion. So the lesson we have learned from other respiratory viruses is that, as Dr. Keiser alluded, the window is very narrow. By the time you develop significant disease, it's too late. Even with flu, if you don't give it in the first 36 hours, its subsequent benefit is much smaller.
Mm-hmm.
Okay. So before the virus replicate, expand its invasion down to the lower airway, you got to get it under control. But most patients with COVID present much later than that. So that's why the therapeutics don't look as pretty. On the other hand, pre-existing immunity seems to work quite well against respiratory virus like flu and RSV, for example. So if you have high level of antibodies, it works great as a preventive measure. Okay. So if you get very early infection, high risk people, we give these antibody infusions. It actually works very well, better than remdesivir. Okay. When the strain is susceptible to that antibody. So immunotherapeutics, obviously, as a preventive measure, is probably good. Or early infection, antivirals will come along, but I don't really expect antivirals to play a big role for severe disease. Mild outpatient illness like flu, you take Tamiflu, I think it's going to go that route, as we had talked earlier on.
Mm-hmm.
But once you have severe disease, it's going to be a combination of different immunomodulators, right? Once the damage is done, how do we reduce that? And that's why there's also a lot more focus there in the therapeutic arena. But again, we are barely 2 years into this, new infection. And considering that, we made great strides, and I'm sure we're going to have more options down the line.
Right. One of the things that comes up that and help me clear up something that so far UTMB has administered 6,400 either through the shot series or the infusions of the monoclonal antibodies. How effective we're seeing that as far as helping folks if they've gotten sick? Obviously it has to be, as I understand it, early on. And I've heard mixed messages on how effective that is with Omicron. And I wonder if y'all could both chime in on that.
Yeah, I think that's been a very, very important thing that we've been able to do is, again, it's one of those things, if you give it to the right person, it can actually prevent hospitalization and death. And when you look at the data, it's actually more effective than remdesivir. It's more effective than anything other than vaccination. And so in an unvaccinated individual, by giving them monoclonal antibodies, that you can do them a world of good. Now, with Omicron, there's only one of the commercial products, something called sotrovimab, has been shown to be effective, and we've been doing that. But because it's been available in limited supply, we screen all of the cases to make sure that they will in fact be someone who will benefit from it, because we don't want to waste it on someone who's mildly ill or not at risk for getting very sick. We want to make sure that if someone who's at high risk, immune suppressed, has any of those risk factors, that they can get it, so we can keep them well.
I mean, it's interesting. I'm just saying, kind of in a way we got lucky, with Omicron. While the antibody repertoire available is smaller, only one of the antibodies really seems to be effective. Fortunately, it's an overall a milder disease for most people. So we are choosing to infuse those who have the highest of the highest risks. Okay. We are still leaving out others who may qualify, but because of the shortage of supplies. But again, the good news is that if most of the folks do quite okay with the Omicron variant, but with Delta, fortunately we had the Regeneron and Eli Lilly products, and we use Regeneron antibody infusions in a big way. was a virus that had high morbidity and mortality. So by
Right.
having an effective antibody that was in good supply, it made a huge difference. But it was needed. We needed that antibody because the virus was much more dangerous. So I think
Mhm.
Omicron, even the antibody supply is limited, fortunately, it balances out. It's a little bit less, aggressive. So, you know, that's just the good and the bad news at the same time. Yeah.
Right. Dr. Keiser, this goes into your role. Put on your. I know, yes, you're still with UTMB, but obviously you put on your role as not only local health authority, but the head of the Galveston County Health District now. There have been adjustments now to the vaccine clinics and the testing. How's the demand on testing going right now? Is being able to keep up because we're seeing. So, while testing is widely available, shortages on the at-home testings and stuff like that. How is that working out right now?
Yeah, so far it's going very well. We're doing a drive-through testing for this week and into next week, and we're really going to run it just based on the need and the demand for it. While there's a lot of testing available, but we've also been getting a lot of concern expressed by citizens about, not being able to pay for the test or, just the test not being done right. And that's why we decided that we would go ahead and open this for the time being. That being said, we are seeing the number of people seeking testing go down. And that's not surprising. That's what we typically see when, as the numbers start to fall. There's both less virus in the community, so there's less people getting sick who need to get tested, but also there's also less of the perception of a need to get tested. When the numbers are really high, you sneeze, and sometimes people go, "Oh, I got to get tested." And
Yeah.
I've had those moments myself.
Yeah.
And
sore throat. Oh, got to go get tested.
Oh, yeah, that happened to me a few weeks ago before Christmas. I woke up and my voice was really gravelly. Man, I was getting tested at 7:30 that morning. So so I understand. I get that. But as the numbers fall, then it's sort of the perception that this is definitely Omicron or this is definitely COVID decreases, and so we see less demand in testing. So the testing things are going well. We're going to see a lot more antigen testing out there. The federal government has announced that you can order your own antigen test. I ordered mine last night. We'll see when it arrives, and we'll see how easy it is to do. And we can talk about that when.
And that's a fair point. Matter of fact, we'll have the link up here just shortly on the rollout. The site went up yesterday.
Yeah.
And I signed up. It was easy in 1 minute, less than 30 seconds. I was done, and I'm waiting for my kids.
Just how I think and I think this may be a mix, but Binax, I guess, is the main kind of one that's being sent out to everyone. How effective are these? I call them at-home tests on that, because we hear everything from false positive and
Right.
things like that, and get some people concerned on that. How effective are those that give you kind of the most important part, peace of mind?
Yeah. Well, I think the most important thing about them is that let's back up. The hard part is that they have to be evaluated in context. Okay. And so people worry about, is this a false positive? Well, when COVID levels are really low in the community, it's more likely to be a false positive test if you use an antigen test. And that's just the way these are designed. Right now, if you have a positive antigen test, you probably have COVID. Okay. That's just because there's just so much of it everywhere. And I think it's going to be very, very helpful, because it will allow people to decide whether, do I need to isolate? Do I need to, what do I need to do about work and my kids at school? And these are all really, really important questions. But the flip side of it is it also helps do I need to go see a doctor about this, or do I need to go see a doctor about something else? One of the things we would urge people to do is, just because you have a negative antigen test and you feel bad, don't think, oh, it's not COVID, so I'm fine. I mean, you could have flu, you could have something else. And so
still need to get checked out, right?
Still need to get checked out. And so I think part of the federal government's desire to get the antigen tests in people's homes is so they don't have to wait in line, so they don't have to worry about, is this a reputable person doing my tests? Because we've seen some unscrupulous people, setting up testing sites. And they don't have to, and they can get the result right away. The most important thing is you got to follow the directions. Okay. And that's the other concern we have is, if people don't do it right, you're not going to get an accurate test. So all the guys out there, myself included, don't just rip it open and start to do it. Read the instructions first. Have your wife read them to you.
I was going to say,
Make sure you're doing it right, and then do it that way and read it. And then they're pretty good.
And we should put up that if you want to go ahead and go online and order the free at-home test, it's covidtest.gov that you can go in and do so. There is no, there's not a salary restriction or anything like that. These are free tests set up for you to get. And they are saying it's, they're not shipping for like a week to 12, 13 days, and will depend on how the demand goes. But if you do want to get those tests, I'm like you too. When I heard that the site was already up last night, we went ahead because it was supposed to roll out this morning. And we went in last night and did that just to have something at home, because we had found that it while it doesn't give a total peace of mind, and I always like, just because I like to see the nurses over at UTMB because they're already always nice to me. And particularly since they like to stick something up my nose every single time. I go over there for schedule up my test. It's actually not that difficult. There's sometimes I have to wait, but it goes in there just to have that for sure, because I'm out in the public so much, and I do get concerned with of infecting other people. So that won't be in there. But let me ask you this, because we had one of our viewers just ask, because of these home tests that are coming on now, what do we do about the numbers? Because no one's required to say, hey, I had a positive test. Now I got to report that to, no one's doing that. So, how are we going to track now? Is it just going to be on those tests that are done?
So here's what we're doing already. So we get antigens reported to us. So anytime a healthcare entity does a test, whether it's an antigen test or it's a PCR test, they have to report all of that. And if you look at our website, what you're seeing is the PCR tests, and that's because still to this day, most people are getting PCR tests done. And it's also a good way of comparing, because we've had the same numbers and we don't have to vary tests. So we made that decision to do that. But one of the things we're going to keep doing is keeping track of how many antigen tests are being done, as well as we can tell with that. But he's absolutely right. It is a concern. If everybody's doing their own tests, we may lose our ability to track this well. So we're going to have to figure out some other ways potentially.
Yeah.
Go ahead, Janek.
I think you're right. All these home-based tests, self-diagnosis is not going to be reported. The only thing is, I think moving forward, again, this is part of maybe developing the new normal, right? That means easy access to test, so you change your behavior, right? And you protect others. But also, I think future data monitoring would depend less on just simple diagnosis of infection or no infection. It's going to be severity based. So how many people present to a healthcare facility for care is probably maybe moving forward the data that people will focus on.
Which is the question I asked earlier. Are we focused on the wrong number by saying this is how many people have tested positive, whereas the focus should be how many people are coming in through a medical center to be treated for this, how many are severely sick, how many are hospitalized, how many are on ventilator. That becomes the measure to watch now, because it is moving to this kind of, I call it a new phase, where it's more of a deal with it thing as someone is at home, getting closer to how we would deal with flu, pneumonia, or other respiratory illnesses along the way.
Yeah. See, I don't view it so much as a either or, but a yes and. And to Janek's point, the CDC has a nationwide network to monitor influenza, and things called influenza-like illnesses are kept track of by hospitals and reported. Unfortunately, that system only runs from October to May.
Right.
Yeah. Right. And so it doesn't do it all the time. But what's interesting is, particularly during this Omicron epidemic, we have seen the number of influenza-like illnesses increase, but we haven't seen a lot of influenza in terms of positive cultures and other sort of tests. So at the end of the day, it wouldn't surprise me if we end up with a hybrid system like that to monitor the spread of COVID in our communities.
And that brings me to the question to ask about, it's kind of catch on as a buzzword here, Flurona.
Yeah.
The combination of both, and obviously, from what I have, the research I've done on this is that it's very rare, but it doesn't surprise me that both would be tested. Is that let me kind of put it this way: is that a real thing, or is it a kind of a hybrid? We kind of think that's what this is, that it's flu and COVID at the same time.
I mean, Janek ran the numbers on this, so go ahead.
Oh, okay, so good. I knew somebody was looking into this.
We look at it weekly, and like this week we had 2 cases like that. Last week we had 1. It's a small number. Whenever you have viruses co-circulate, right, you're going to have statistically, certain number of people who are going to encounter both viruses. It's going to be always small, but it can grow if both viruses are, amplifying in the community at the same time, right? There's going to be 10%, 20% of people who could have any combination of 2 respiratory viruses. We've seen that with other viruses too. So to have a COVID positive, flu positive is no different in our mind. COVID positive with rhinovirus, another virus positive, or metapneumovirus, right? It's just going to happen. It just depends on what's the prevalence rate of both of these viruses and randomly. The other thing we have learned from other projects in the past is that most people really don't get both infections simultaneously, meaning on the same day, okay? One came little bit before the other, typically at least a week apart. And when you're looking at the presence of these viruses by molecular tests particularly, the molecular signature remains in the nose for quite a while. So so if I'm testing today positive for flu and COVID, it's hard to know which one came first. Now, in the research setting, we look at the amount of virus. When we use molecular platforms, we can tell how much virus one was, compared to the other. And we can say, well, one is in lower quantity now. That means it was the earlier one. And the one that has higher viral load is the one that is the current one that's making you sick. So it's unlikely most people are getting sick simultaneously from the same virus at the same time. Okay. It's a sequential thing, but we just happen to catch it with a diagnostic.
And the test comes and it picks up both at that point. Dr. Keiser, you mentioned something about kind of keeping a track on some of these folks that are doing testing. I know that some of these calls came into the health district too. Let me just ask, there was some clinics that popped up in parking lots just out of the blue. I say clinics, they're testing centers that are drive-through. And there have been some folks that expressed some concern. First, let me ask you, are those in any way regulated by any entity?
No. So anybody can do it. You could take your tests that the federal government gave you, your 4 tests, and go out and stand on the street corner and offer to do them for people.
And actually, the interesting part is that anyone can set it up. All they need to develop a relationship with a payer, and then the bill and collect. That it has just no.
So you don't have to be licensed.
There are no guardrails there at all.
No, don't have to be licensed. Don't have to have any of that.
Nope. Anybody can do it. You can do it off the back of your pickup truck.
That's the kind of the feeling I had from what is this? And I went over to one in Texas City. It was kind of watching the operation, going, I'm not so sure about this one.
Yeah. So just to keep you up to date on things, we've received some complaints about a particular site that they were not changing gloves and not following proper protocol, and somebody complained, and they actually complained that it was our people, and initially we looked at it and we go, gee, that's weird. And of course, when you hear that sort of thing, you always want to make sure, did we really do that? And the answer was no. And the more we looked into it, we realized it wasn't ours. And then so one of our staff just drove down to several sites in Texas City and stood there and watched. And sure enough, the people weren't doing it. So we talked to them, and they've actually changed their procedures and changed their protocols. And we've had a chance to go back and work with them, and also to work with them to make sure they're actually fulfilling the reporting requirement. So if you're there are 2 areas where we can intervene. One is that if they're not following proper infection control practices, if there's a contagion in a building or in a site, we can intervene then. And then also in terms of reporting, we can intervene in those 2. So if they're not reporting, we can do that. But I've seen them all over the place. I saw one at a gas station.
Yeah.
And just drive up, get your test, go in the gas station, get your donut and coffee while you're waiting for your result. So
Well, and part of that too is I had complaints from folks saying, "Well, they're charging me.
yeah,
They're not supposed to be charging me."
That's great.
And I said, "Well,
That's
here's
great.
the thing.
So
There's a handling fee that can be charged.
Handling fee, the reporting fees, there's stat fees. There's an urgent care center that goes, oh, we don't do tests. So you're driving to get a test, then they draw all your blood and give you IVs and do all sorts of things. So, so there are a lot of there's some unscrupulous people. There's some that are kind of on the margin. And if you're not sure, come to the health department, go to UTMB. Right now at the health department, we're not even taking people's insurance information. We're just doing it. We'll do it as long as there's a need for it. For UTMB, for any county resident, if you don't have the ability to pay, you can get your test done. And so insurance is billed. The government does allow a nominal fee for collecting and reporting. So some people may get a bill for like $20, but the rule is that they can ask but not demand, right? So you don't withhold the service for that. And the reason why some places are charging nominal fees is simply because it is an expense, and it helps to defray the cost of setting that whole system up. So we have a very good system in our county. I think we have a lot of capacity, and you can go to trustworthy places and know you're going to get a result that you can count on.
Obviously, we talk about UTMB, and I have the site if you want to find out about testing and as well as vaccines or any other things, that there, utmb.edu/COVID-19 is there. The health district site where you can find about the new drive-through testing and even if you need to get a vaccine, gchd.org, but also too Walmart pharmacy, Kroger pharmacy, CVS pharmacy, Walgreens pharmacy. The availability of testing and vaccines at already existing locations that can be trusted is already in place. And as I said, and I know you said you're working with the folks there, but if you see someone just pop up in a parking lot there and it doesn't have a UTMB flag flying over it, or health district flag flying over it, or Walgreens or CVS, you probably need to kind of move on just to be safe and go there. But there are other clinics around that are offering it as well, that have reached out to us as well about, hey, let people know we have them available. A lot of times they'll put out to say, well, UTMB no longer has any more tests, which is inaccurate. And so, or the health district doesn't have tests, which is also inaccurate. There are plenty down there to get tested there. So that's what we wanted to make sure we were passing along to folks as well.
Yeah. So what we noticed was that, right before the holidays, there was a real crunch on testing. And that was because so many people wanted to travel and they wanted to go visit their family and make sure it was going to be okay. And but as soon as we got past the January 1st, we saw the demand for testing drop and a little bit. And then there was a lot more, availability for people. So there's plenty of availability, and there's plenty of availability from reputable healthcare delivery people, and that's what we would recommend.
Gotcha. Dr. Janek Patel, UTMB Health, Dr. Philip Keiser, UTMB Health and Galveston County Health District and Local Health Authority. I don't know how you put anything on your business card with all those titles you have. You got to throw them all out every single time out there to make sure which hat you have on at the time. Thank you all both for being on with us, and thank you all for your questions. Hopefully we got to most of your questions throughout there and got those answered. And again, it will be having that. Dr. Keiser and I will be back together next week on Tuesday, back to our regular schedule. We took somewhat of a break, and it was my fault last week that we didn't get to do it. Had some stuff come up with a staff member who tested positive or thought he had COVID, and turns out he wasn't. He was fine. But we take those precautions as well. Like, okay, go get tested. Let's figure out what's going on. Stay away from everybody for the next few days till we have the results, and then go from there. I do want to ask on the masking and everything else that gets into an area, folks get upset about. let's just take the vaccines off the table. Let's take everything off the table. What can folks just do to keep it that lowers the risk level on a regular, everyday basis for themselves? Yeah. Knowing, by the way, masks not necessarily to protect you from something getting to you, although it does help, particularly the N95s that way. It's more not getting someone else. But what should the common practices be from folks right now?
I think the number one thing is limit where you go. And, that's not telling people they have to stay locked up inside their house, but just be cognizant. We've talked about this a lot in the past, but be cognizant of where you are, avoid large crowds if you can, and just be aware. Masking whenever you go out and about, surgical mask at the very least. We all had those homemade masks. I certainly had a few of those, but they are not particularly good with Omicron. And so at least a surgical mask, if you can wear two, that's fine. If you can, if you have the lung capacity to wear a KN95 mask, go ahead and do it. But I can tell you, those of us who have, had to do that as part of our work, if we can avoid it, we can. That really is the best thing. And I think those are probably the most important things. Just, be careful. You see lots of crowds of people, nobody's masking, nobody's doing anything. And you got to stand in line next to people breathing on you and coughing on you. That's probably not a good place to be.
Let me ask on the K95 mask though, is that on those, if I'm in a gas station and I see they're selling something that has K95 or NK95 on it, should I be buying that?
It's a good question.
Yeah, that's the answer I needed to have there for that, and not me that I would. I get my supply, but I just, it is one of those things. It's kind of like these testing sites that are popping up. Folks will take advantage of them.
FDA sent some warnings. Up to 40% of these masks sold in the community are actually fake. Okay.
Yeah.
So buying it from a reputable dealer or shop would be the best way. Like going to a pharmacy to buy the mask or department stores rather than picking it off some roadside kiosk or gas stations. But we are facing this challenge in the healthcare system. Sometimes we actually end up buying fake stuff. We don't even know it until it arrives. So because we often are forced to buy things when there's a shortage, right, from anyone who sells us anything, and we learned the hard way. But actually right now from reputable manufacturers and distributors, as far as, legitimate entities wanting to buy them, there are plenty of them available now. So a lot of stores that are reputable stores, go to chain stores. They're more likely to have real thing.
They're not hard to get, by the way. They're fun of, I swear, I was grabbing something to drink at a convenience store. I looked over at the mask. I swear it looked like a Mr. Coffee filter that had straps at it. And it had like a weird initials 95 at the end. It wasn't even K95. There was something else. And so it's buyer beware at those type of things. Again, thank you both for coming on with us. We appreciate it. We'll try to keep up with everything. Hopefully by this spring, we're just talking about, okay, things have eased up a little bit, keep your guard up and do the next things about it. I should ask Dr. Patel, from the system standpoint, are there any, because we've heard of some hospitals that are pushing off some procedures that would normally be elective. Is any of that happening in UTMB system right now?
Oh, we just had our own incident command meeting this morning to review the status. No, we actually are not delaying anything just because of COVID surge. Obviously, we do test people for COVID prior to procedure. Mm-hmm. If they're positive and they are elective things, we do postpone. That's just your normal isolation process. But otherwise, we are not canceling elective procedures because of another issue. Yeah.
All right. Thank you both for being on. As always, great to have you both. And I know we've really all gotten to know each other real well over the last year and a half. And but it's going to keep going, I think, for a while. So thank you, Dr. Janek Patel, UTMB Health, and Dr. Philip Keiser, Galveston County Health District, Local Health Authority, and also UTMB Health. Thank you all for joining us here for this edition of Healthcare Unmasked.
Thanks for the